Okay, so this is Cat 3 protocol for SOT. First step that we have to do is our leg length inequality. So we go and we check the medial malleoli of each foot for superiority. Patient has a right short leg, so we're just going to file that away for later. Next thing we need to do is the glute fiber analysis. Now that's similar to the cat fiber analysis that we've done in other protocols, where we have 5 spots, one being on the PSIS, and then 2, 3, 4, and 5 going outwards on the iliac crest. Number 1 is going to correlate to L5, number 2 to L4, so on and so forth. And what we would do is we would go one by one across each segment. We'd find the most tender one, correlate that to the appropriate lumbar vertebra, make a knife edge contact, and adjust I to S. Next, we've got our indicators that we need to confirm that we are indeed in Cat 3. They're helpful in making the diagnosis. So we would palpate the sciatic or short leg at the calf, at the hamstring, at the glute fibers, and then at the temporospheno line for tenderness, and that just lets us know that we're on the right track. The next thing that we do is SOTA, which is step out, toe out. So I'm going to take the patient's leg, I'm going to rotate it out until I see the glute fibers start to bunch. I externally rotate and I hold it there for about 15 seconds. And then after I've done that, we let the body relax for about 2 minutes, and then we draw it back out and do the same thing again. Now we're looking to see if the second time was better, worse, or the same than the first. If it's better, that means we do have true sciatica. If it's worse, we have a segmented or sequestered or fragmented disc, and if it's the same, it's probably a lumbar herniation or some other discal lesion. After we've done that, we can get to our Cat 3 blocking. So for her short leg, or for the patient's short leg, it's a passive modality, so you ask if they have any knee problems. If not, then you're going to lift over. The first one goes a little bit lower than the long leg. It goes underneath the trochanter, pointed inferiorly. And the second one points the same direction, but it's higher. It's up on the ASIS. So once we have them blocked, we wait about a minute or two and ask them how they're feeling. If they're feeling good, we can leave them there for up to 30 minutes, but if they're not feeling so good, then we need to go ahead and we need to do our block augmentation. And the way that we achieve this is by taking the blocks and basically wiggling them inferiorly or rotating them superiorly, whichever way you want to look at it, about 5 degrees at a time, to see if we can give them more relief from what we're doing. We start with the short leg, but if that doesn't resolve the problems, then we'll probably place it back to where it was and then start with the long leg and see if we can get it that way. Now once we have them on the blocks, we've got a couple exercises or a couple procedures that we need to do. The first of which is the posterior iliofemoral ligament. So we're going to take the patient's feet, we're going to rotate the toes towards each other, and we're going to see if one or the other rotates less. And in this case, her right leg doesn't rotate as much as her left. So I would come up to the greater trochanter, I would go an inch posterior and an inch superior, take a double thumb contact, and then thrust lateral to medial through the opposite obturator foramen. After that, we've got our lumbar derotation and our lumbar inferiority. Now the derotation, what we're going to do is we're going to confirm it through palpation, but then we flex the patient's knee, and after checking for TVP tenderness in the cervical spine, which correlates to SP rotation in the lumbar spine, we would then ask the patient to inhale, and then we would push lateral to medial on the affected spinous. We do that 3 times for about 5 seconds. The inferiority correction, instead of checking the cervical TVPs, we're going to check the cervical SPs, and that's going to correlate to a tender TVP in the lumbars on the same side. So once again, we flex the knee, we have the patient inhale, and then we push P to A and a little I to S on the affected TVP. Again, 3 times for about 5 seconds. Next thing that we have to do is our acetabular goading. So once again, we're going to flex the knee, but this time we're going to bring an element of external and internal rotation. So we externally rotate the foot to contact the anterior portion of the hip capsule, and then we do friction massage, look for adhesions, break them up, that sort of thing. And then we internally rotate so that we can get at the posterior portion. Again, looking for adhesions, breaking them up with a transverse massage. After that, we have our orthopedic. So we're going to remove one of the blocks, and after we've removed one of the blocks, if we have a spinous deviation to one side or the other, we remove the block that's in question, and then that's going to lift the pelvis to one side or the other, and the spinuses will deviate back towards that side and correct the rotational component. Next thing we have to do is our sciatic traction. So we would figure out which of the legs is truly sciatic, and then we would take a double hand contact on the patient's ankle. They would brace the head at the head of the table, and we would just pull for 5 seconds, 3 times a piece, or until the symptoms resolve and go away. Now there's also an assisted one, where the function is much the same, but the doctor comes in and affects a certain lumbar segment while he has an assistant traction the leg. He's going to put his fingers above the disc in question, and he's going to push P to A while the assistant pulls S to I on the leg, and that'll give us decompression of the disc in question. So once we've done that, we can remove our blocks, and we go to our sacral base test. And once again, we've done this in another protocol, so what we're going to do is we're going to contact the sacral base. We're going to have the patient cough, and the direction of which way it goes is going to tell us whether they're positive, negative, or neutral. In her case, it went straight up towards the ceiling. That makes it sacral base positive. So what we would do is I'm going to contact her sacral apex, and I'm going to push inferiorly as she inhales. And then I'm going to relax and release as she exhales. And we do that 3 times for about 10 seconds per time, or until the symptoms resolve and she feels better. Now we have 2 more things that we need to do. There are our post-blocking techniques, the first of which is going to be our sitting discal lesion. So if I could get you sitting up and facing away. Now this once again is going to go for a discal lesion in one place or another. We would find the affected segment in question. We would contact the the SP, the inner spinous space above the disc in question. She's going to tuck her chin to her chest and then flex forward and take a deep breath in. Then she's going to reverse those 3 things except for keeping her chin to her chest, and I'm going to apply a P to A pressure as she does that. And we do that 3 times for about 10 seconds through the whole protocol. The next thing that we have to do, the last thing we have to do is Kitty. The next thing we have to do is our side posture. So if you could be, the 2 things that you have to make sure to do with this is to make sure that the sciatic leg stays down, and that also the spinous deviates towards the sciatic leg. So in this case, they would both be pointing down. What we do is we would take the top leg, and get this one straight, take the top leg, popliteal fossa goes against my knee, we traction it out, contact the PSIS, and then provide a P to A thrust as we do so. And that should help alleviate some of the symptoms of that sciatic leg. And that, my friends, is the end of Category 3.
It was close.
Sheesh. Nice. Look at this. Close, close. It's amateur hour here.